Welcome to the Fresh RN podcast. The information contained in this podcast is meant to supplement your existing knowledge and not replace it. Always refer to your state board of nursing, standards of care, and respective institutions' policies to guide your practice. All identifying patient details have been changed to protect their privacy and remain compliant with the Health Insurance Portability and Accountability Act of 1996. Thanks, nurses. Stay fresh. I want you to step up on your cardiac soapbox for just a minute. He does this little dance.
Birdie was happy.
That patient needs, she's like, no, it's, and I was 120, and she was like, this looks great. And I'm like, honey, no.
So, speaking of cardiac rhythms, God, heart blocks, they're like the devil to me.
I love that.
You don't make my hands sweat because everything is different. I tell my husband, if we have like a kid that we can practice on first.
Welcome to the Fresh RN podcast. My name is Katie Cleaver.
And I'm Melissa Stafford.
Thank you guys for joining us. And we have a wonderful guest here today that I am elated to have here.
Woo!
This is Nacole. You may know her as Nurse Nacole. She has a wonderful blog.
You're being too kind. Way too kind.
But I really want Nacole to introduce herself, and I would like you to kind of focus a little bit on your clinical experience. And kind of also a little bit of your blog. So you could give us a little rundown of who the heck you are.
Who am I? My full legal name is Nacole Riccaboni. Born and raised in Central Florida, kind of Kissimmee, Disney, Orlando area. I'm probably the only person that's ever born and raised in Florida. No one's ever from there, but they moved there later in life. I became a nurse in 2011. I started out on a progressive care floor kind of multi-system.
Okay.
I did that for a year and a half, 6 patients, very overwhelming. I went in as a GN on that floor with 6 patients. It was very difficult, but you learn time management like crazy.
Were you on day shift?
Yes.
Sweet Jesus.
I was on day shift, 6 patients. It was very overwhelming. I had really good time management skills when I went to ICU a year and a half later.
Oh, I bet.
And I've been at multi-system ICU since then.
Okay.
But a year and a half ago, I went to the VA for about a year, and then I missed my home, and I went back to where I work at now, which is Florida Hospital.
And tell me about, you're in graduate school.
Yes, I'm in graduate school. It's a emergency doctorate, nurse practitioner program. So it's family/acute care doctorate.
Oh, wow.
I really don't know what I want to do. But in Florida, to work in most hospitals, you have to have that acute care if you want to work in critical care.
Mm-hmm.
They no longer allow F&Ps to work in the ICU setting.
Okay.
That's what I was told by a provider.
I've heard that too, but it's interesting that they have that dual program to be able to get that for you.
Mm-hmm. It's very interesting because I don't know if I want to do ED or ICU. They're both kind of critical care in my eyes. So I was like, I know that once I'm done, I'm not going back to school. So let's finish this now. Let's have as many employment options as we can have. Because once I'm done, I am completely done.
I respect that thought.
Yeah, and I have a master's in a year and my doctorate in 2 years, and then hopefully I'll find a job at a hospital.
Oh, you'll be great.
Oh yeah. Well, and you're also a mom.
Yes, that's the biggest part.
Yeah.
I'm a mom. My son is 3 years old. He was diagnosed with autism March of this year, so it's been a whole new learning process. I know about DKA and liver transplants and sepsis. Autism was brand new to me.
With a child.
The first child. I tell my husband, if we had a kid that we could practice on first and then have Rocco.
Have the one with the autism.
That would leave me less anxious. But with autism, you're constantly, am I doing the right thing? Is he freaking out because he doesn't understand what I'm asking, or he can't communicate what he needs from me?
Or is he being a normal 3-year-old?
A normal 3-year-old temper tantrum. So
Yeah.
I'm constantly criticizing what I'm doing. Mm-hmm. I think I read up a little too much because I have all these tactics, and my husband's like, you're freaking yourself out. He's 3. He's going to kick the wall. It just happens. It doesn't mean anything. Yeah. So I think everything means something, but it really doesn't.
So needless to say, you got a lot going on.
A lot going on.
But, so you experienced critical care nurse.
Yes.
In graduate school.
Yes.
Very experienced with time management.
Yes.
Cardiac.
Yes.
And family work-life balance.
I'm trying to. I work nights and my husband works days, so we kind of do the taxing parenting. He gets off work at 5 o'clock. I go to work at 5:45.
Yeah. And
luckily, the only day we have together is Friday. But I work the Thursday night, so I'm always making myself stay awake. Like, oh my God, I love this.
But I'm so
tired. I would love to watch a movie with you. I'm gonna try not to fall asleep. I'm gonna really, really try.
It's not personal.
He's very appreciative. He supports me. So
So what I wanted to do, though, is have Nacole on the podcast to talk about cardiac. We have 3 episodes that dive really deep into neuro, and that is kind of me, Melissa, and Elizabeth's specialty. But we don't work CCU. We don't have necessarily that that inch wide, mile deep, knowledge base with cardiac. So we wanted to really leverage Nicole's expertise with cardiac.
I don't know if that. I don't know. I know a little bit of something about everything.
So we want to. We know a lot of you guys are new grads. A lot of you guys are actually new grads in critical care. So we wanted to ask.
Wow.
Yeah, we get a lot of questions about people who are brand new to nursing and in the ICU setting.
That's a new thing that's happening. We just hired 15 new grads on our floor, and it's very daunting.
Yes.
I really wanted ICU when I graduated, but I'm glad I didn't get it because I did not have the proper mindset or skills to manage somebody that's sick.
We all 3 of us worked a lot of critical care, but all of us started out in med surg or step down.
Yeah. That was how it went back in the day.
Yeah.
But with the shortage and the need,
a lot of people
are there.
And it's not impossible to do, but you have to work for it, and you have to have that discipline.
Yeah.
It really is going to take a lot of discipline. So,
and I know GNs that hit that ground running. They're very organized, very professional, and they're amazing caregivers.
Yeah. So, and actually, I didn't even say this at the beginning. We're recording this podcast episode from Houston at the National Association of Critical Care conference, NTI. It's a big conference. Gone to it quite a few times, and I love this conference.
Me too.
And we actually went to a session today about precepting the struggling new grad. And they had some great points, but one of them was if you have a new grad that is not taking, and I'm trying to remember the word she said, accountability, or what was that? What did she say?
It was accountability.
Accountability for their own learning. That's a huge red flag. And there's no way that you as a new grad ICU nurse can be successful if you're not taking the accountability for your own mistakes and owning up. So if you're making excuses and pushing away mistakes and not taking accountability for them, that's a huge red flag.
And taking the initiative to learn on your off times too.
Because you have to go home and learn. You have to go home and look at EKG stuff.
And I try to tell students that we work 12 hours. We have 2 patients. Me and your conversation might happen every now and then, but we're usually at the bedside taking care of the patient. If you want to read up on CVPs and A-lines and Whipples and things like that, that's fine, but you will not just sit here and not take care of the patient because you want to learn while you're clocked in. I get it. You don't want to do it at your house, but everyone learns at their home.
Right.
Well, and you're not going to retain it either if you're not.
If you're getting up and checking vital signs and drawing labs, you cannot successfully educate and absorb something at work. It's not possible.
Yeah.
So I want to dive into some cardiac stuff. So your experience is kind of more so in that area than ours. So our first question is, what's like one of the first things a new nurse should really understand about cardiac? Do you think it's anatomy of the heart, certain medications, a solid EKG rhythm interpretation? Like, what do you, now that you're an experienced cardiac nurse, what do you think is, the most important thing for that new graduate to really
focus on first?
In my opinion, it would be the anatomy followed by the EKG. Many times you see the EKG and that kind of leads you to, well, what's going on there? If you knew your anatomy and you knew the P waves and the QRSs and you knew depolarization and repolarization, you wouldn't really have that question. So anatomy first, then that EKG, and then for treatments and therapies, followed by the medications. Sometimes GNs do it in reverse. Well, I know all these drugs and I know what they do. Do you really know what they do? What is the expected outcome of the drug? Are you expecting a systole? Are you expecting the heart rate to go lower? You have to know those fundamentals first before you jump to pharmacology, because you're going to get confused quick.
And I like knowing the anatomy of the heart and the blood flow of the heart and the mechanical, and not just the mechanical structural, but also the electrical, like knowing that
elements
inside and out, I think is so essential, because if it reminds me of neuro, and I'm sorry I connect everything to neuro,
no.
but thinking about where is the stroke and what can I anticipate? Okay, where is the physiological problem in the heart? What can I think to anticipate? Do I have a mitral valve issue, or do I have, what kind of heart failure can I expect? Okay, I have a patient that has chronic AFib. Well, they'll probably have some issues with heart failure at baseline. Are they they have anticoagulants and like that kind of stuff. So like understanding the mechanical and electrical stuff inside and out. Sounds like
because a lot of
priority.
GNs know the treatments. They know the treatments, they know the meds, but they have no idea why it's happening, and they can't articulate what's happening to an EKG. So they're really smart on the back end, but with the fundamentals, they seem to miss that or it not be of importance. We had a GN during the code, and I'm like, "Is there a pulse?" And she's like, "No, with the monitor though." And I'm like, "Is there a pulse there?"
PEA
We've been through that. She goes, "Oh yeah, I forgot. I get it. You love technology and you love the monitor. Is there a pulse there? Because that can be inaccurate. Is it true asystole? Are the leads right? Like you have to go back to
Is it PEA?
Even first.
My last code was actually, I love that. I love that you said that. I say that all the time. When you walk into a patient's room, in neuro, obviously, but it's applicable across the board. When you walk into the patient's room, look at the patient first. Doesn't matter what the monitor says. If your patient's blue, it doesn't matter that the monitor says your stats are 100.
You're so surprised. They're like, "Oh, the blood pressure's 200. Is your transducer right? Oh no, it's on the floor." You have to look around. I get it. The monitor is fascinating and it's blinking and with technology now. Everything looks beautiful on the waves. You have to old school. I need you to look and see what's going on.
Yeah. Well, it's not old school. That's the right side.
It should be.
It is. I really don't equate that with old school. I mean, I know exactly why you're saying that because technology has an important role for where we are, but it really is about what the patient looks like.
Yes.
You can have a patient who looks in distress, but the monitor looks fine.
And they be completely fine.
And you can also have a monitor that looks awful. But the patient is perfectly normal. Yep. So it can work both ways.
And that connects again to neuro. I'm sorry. Y'all, I got you. But it's like the patient who has the CT scan that looks horrendous. Yeah. And then you go in the room and they're fine. They're just hanging out.
Yeah.
Or you have the patient who has that little baby bleed and then you go in there and they're obtunded. You know? Yeah. Like patients are dynamic and you really can't just look at all diagnostics and say you know exactly what's going on.
Because a lot of GNs, they get their textbook and they're like, okay, boom, COPD, I'm going to see all these symptoms. I'm going to see all these symptoms. And then we'll have a COPD person just sitting there, breathing fine, lungs are clear, and the GN's like, I don't understand. I was like, it doesn't always present that way. Yeah. Or maybe they're coping well, they haven't decompensated yet. It's some chronic diseases take a while to present themselves. It's not like the book all the time.
Yeah, that's good. That's good. I really like that.
So from a little bit of different perspective, because, the audience, I feel like is a lot of new grads, but I work in a neuro ICU. I feel like I've got a pretty good grasp of neuro, but I get floated to the cardiac ICU. What do you think that I need to focus on most when it comes to, or focus, is that the right thing? Yeah, maybe focus on most by walking over there. And sorry, go ahead.
Well, like when I think about neuro, I'm like, okay, the sodium is the big thing, one of the big lab, the sodium for the neuro patient. So, like the neurosurgeon and the neurologist care about the sodium. What's the lab for the cardiologist?
Where when I get floated to see the ICU, and even me, I'm like, oh, I'm swimming, I'm nervous because I usually do multi-system, but we get floated there quite often. And the first thing I usually want to know is cardiac history, any current procedures, and they're really big on potassium.
Yep.
Really
potassium,
big
y'all.
on potassium. Now, where I work at a multi-system, nobody cares about that. They're like, okay, it's low. I'm not worried about that. With sepsis, low K, that's the least of my concerns. But the cardiac surgeons, those electrolytes, they're really big on them, and the cardiac history is a big one too.
And they're proactive about addressing them. They're not
very diligent.
They're not going to wait until the K is 2.2.
No, not at all. No, not at all.
To address, okay, we're 3.2. I'm gonna give whatever a K.
Are you kidding me? They're 3.8. Let's give them a little something.
Very,
that K above. But let me just throw in this little tidbit about potassium. For new grads, please understand that your body won't hang on to potassium if your magnesium is low. So if you have to replace magnesium and potassium, replace your magnesium first because your body will hang on to the potassium better.
And I've seen nurses replace potassium over and over again. Like, what's the magnesium? Oh, it's 1.2. You're never gonna get that, dear. You're never gonna get that.
And then you have all this ectopy and, So just a little tidbit.
That's a great
magnesium and potassium go together, but the mag is going to make you hang on to the potassium.
And a mag doesn't come on a BMP. So, keep that in mind, too, if someone's doing a daily BMP.
My GN asked me that. I said, it's not on a BMP. She's like, no, it is. And I'm like, no, it's not. It's
BMP
not.
mag and phos is what a lot of phezicians will order.
That goes back to the Chem 7 and Chem 13s, which you never say anymore. Really.
You don't.
Right. Right.
Oh,
God, I missed
old
that.
nurse joke. Okay. You guys
Showing
don't
my
get
age.
it, but it's okay.
Oh, God.
So yeah, but anyways, aside from that, I guess we kind of didn't really allow you to answer that question.
No, you did.
So floating, so potassium, and then knowing their cardiac history is huge.
Yes, because sometimes the parameters are different. I've gone to the floor and I was like, okay, bradycardia, 60. Under 60.
Yeah.
I'm going to call. And they're like, no. That's expected after this procedure or surgery. You should know that. So every time I go on the floor, I'm like, what are your parameters to call a provider?
Yes.
Like, what's optimal vital signs for this floor? I never assume it because I've gone to neuro before, and they were like, why is your blood pressure so low? And I'm like, oh, my systolic is 120. No. We keep it. No, honey.
No.
You know how many times I have been told when I get there, your blood pressure is really low. And I'm like, it's the systolic, it's 120. They're like, where do you work at? I was like, I ain't floated, I'm sorry.
I love that.
Neuro makes my hands sweat because everything is different. It's different.
that's
Everyone's so
funny.
sick. I'm like, I don't get brain stuff.
You know what? So one time I'm having my flashback because I floated to a cardiac ICU and I floated to the cardiac ICU, but they actually had a neuro overflow patient there who's I mean our neuro ICU was full, but a different nurse had this patient just because of the way the assignment worked out, and the patient's systolic was 120, and I was like, you gonna start neo? Because
little birdie, what's happening?
That patient needs. She's like, no, it was 120, and she was like, this looks great, and I'm like, honey, no. Oh my God, do you see? But then when she pulled up the orders, it was like, oh wait, the parameter was
the thing is the parameters are there. You just don't tend to look.
200 probably.
is what it was, and she was like, oh, but this is fun, but it's like, wait a second. So it's very important when you're on a unit that you're not familiar with to make sure that you're finding out those
and not
little
to
things.
assume because I thought I was like, oh, you guys are playing games. My blood pressure's fine. I mean, is it because I'm afloat that you don't trust me?
Are you
and they were
playing
like,
games?
did you look at the orders? And I was like, oh, no, I did not. I'm sorry.
Yes.
I apologize. Yes.
Yeah.
Look at your orders.
Look at your orders.
And I think
Not what somebody told you either. Look at your orders.
Yes.
Oh, yes.
As
I've been
much-
there before. Oh, yes.
as much as you might love that nurse that gave you a report, never trust them.
Yeah.
No, and
you
they may have had a rough day or night, or maybe they honestly
They got their
didn't
patients
see
confused.
something. They got something confused. I've had nurses that I've followed, that wonderful nurses, and it's like, oh wait, the monitor's set wrong for the wrong parameters that are in the chart that reflect what the physician said.
Right.
So we've been doing the wrong thing all
Wrong
shift.
thing for 12 hours.
Yeah. So it's really
I've
important
been
to
there.
be
Wrong
diligent.
drugs being hung, wrong stuff being scanned. It happens.
Yes.
It's, human error. We're humans. But when I start my shift, I make sure I don't trust anybody. And my GN's like, no, but they told me, and she told me. I was like, I understand what they told you, but this is all conversational.
Yeah.
Show me the orders that we have, the pressors that are available to us, and then we'll keep moving.
And it's not personal that I don't trust
this
you.
is an accountability
I don't trust
thing.
either of you.
This is
I'm going to
healthcare.
double check because this is healthcare.
This is
It's not
healthcare.
personal at all. Yeah, I love that. Okay, so knowing, and I remember that when I worked progressive, or I guess that would be progressive cardiac for a couple years, but it was like, okay, this patient had a mitral valve. What are the expectations for this? And knowing, okay, they've got a mechanical valve. Are we talking about what's the anticoagulant and like what's that kind of stuff? And okay, the patient had stents. Are they going home on Plavix? Like knowing those kinds of things is really, really important because you as the nurse really need to be checking up on that stuff if the physician hasn't done that stuff.
Right, and I know my scope. I know my floor's expectations of our patients. I know what vital signs they're trying to achieve. When you go to a different specialty, you need to ask as many questions as possible because you think you know something. You might be really, really good at DKA, you might be really good at sepsis, but you go on a neuro or a vascular floor, I have no idea what they're talking about.
Yeah.
Biphasic. I was like, what? We don't check pulses that often here.
Yeah.
Here we do that.
Yeah.
You didn't chart that. Oh, I did not know that. Now when I float, I make sure I have a little notepad and I write down the expectations of me because I don't know.
Yeah. Floating can be a little scary, but it's definitely, so make sure as a new grad, when you're dealing with some cardiac patients, you're floating there, you're paying attention to the potassium, the magnesium.
Yes.
Your labs are huge, your electrolytes are huge. Those cardiologists, those cardiovascular surgeons, EP docs, they care so much about the electrolytes. So it's really important to know those and making sure you're familiar with the specific disease process and the nursing considerations that go along with those.
Really true.
All right. Which one do you want to do next?
Well, I was kind of thinking about going to neuro. You know, like we talked about in our episode about neuro, when we start really getting nervous for our patients is if the patient's getting sleepier and more difficult to arouse. And so I'm like, when do you think cardiac nurses get the most twitchy with their patients? Is it a blood pressure change? Is it a rhythm change? Is it a like, yeah, like, is there a time when you think that they start getting a little more, like, that nurse that's experienced is like, something's not right, and they're, you know, they may not put their finger on it, but it, you know, I just kind of wonder.
Something happens.
Right.
It's usually with the ectopy. There's always some sort of monitor ding or something changes. The blood pressure they were hypertensive all shift, 170, 180, and now we're down to 95, and the map is still 65. So technically we're good, but who has a drop that big?
Yeah.
And you walk in and they're like, no, I'm fine. I'm just sleeping. And even if you were sleeping, that naturally does not happen. So, you know, that worries me. The physical presentation, usually in my case where I work, tends to come second to the monitor, vital signs, and things like that.
Which is very different than what we're used to.
Right.
It's the
I bet.
Yeah.
Because they feel fine. They're compensating very well. They're doing great. And that monitor changes in an hour, 2 hours, they don't feel so hot. They got a fever. Their chest hurts. Now you hear the crackles. That usually comes second. So I'm one of those people that if something's dinging, what's going on? I'm not one of those, well, if the ding went off, I'm not going to walk in. No. What happened? I do my little monitor review. It gives me the alarm history. Why's your blood pressure? Your blood pressure hasn't been this low all day. I might go back in the chart, look at the last shifts, systolics. And this isn't normal. And doctors tell me all the time, why are you calling me? This blood pressure is normal. It's not normal for this patient.
For the trend that's been happening.
Right. This is a change in trend. Can we get I'm one of those, can we get some labs? Can we get something so I can be proven wrong and I can be okay my shit?
Yeah, I like that. So I think that's an important thing. Prove me wrong.
Prove me wrong.
But then also, just because not a lab value, a vital sign is technically within normal parameters doesn't mean it's normal
for that person.
Especially with those trends and stuff. Because I remember I had a patient, or it wasn't my patient, but I was sitting at the nurse's station, and the heart rate, it wasn't going off, but it was 120, and the patient had been on a cardioverter drip for 2 hours, and they had flipped into AFib with RVR, and they had started a cardioverter drip, and it's like, okay, this patient shouldn't have a heart rate of 120 with the AFib of RVR, like. We need to be titrating. Something's going on.
Something's happening.
We can't just, even though it's not alarming, we got to deal with this.
Right.
So it's like noticing those so you can't totally rely on the alarms constantly before you do something, I guess is the point I'm drawing.
And people tend to negate alarms because it'll ding ding and it'll stop. And they're like, oh, it didn't, whatever happened didn't last very long. I'm not really worried about it. Then it'll happen again. Yeah. And it's like, you're not going to go check that out. Like, you're not worried about what's happening. Like, the length of time determines whether they're worried or not. And not in my case. I need to go see I'm just nosy. I'm naturally nosy. People know not to go in my patient's room. I don't want you touching anything. I don't want you getting any water because they might vomit. I know the whole program. I appreciate you helping me. Just call me up. Yeah. Because every time someone's helped me, they did something wrong, or the patient got sick an hour ago, but nobody told me till just now. So I'm one of those nurses. Just tell me what they need. I'll go in. Yeah. I'm good. I hover. I'm weird that way. Because people get sick quick, and people are living so much longer now. 90-year-olds, 95. Any slight cardiac issue, it's not good.
And I think that's important too, like the length of time, because I've seen, ectopy, and with you have just a few PVCs. Yeah. But then, and that makes a very short noise. But then what if that's every 5 minutes? Right. And it's long enough for you to kind of forget about it. Right. But then you pull up the history and it's like, wait a sec, they've been having PVCs relatively frequently. They're just not sustaining. Right. But it's there. Yeah.
And it can definitely turn into sustaining. Yes. Right. Those PVCs can turn into VTAC if you're not being mindful of what you're doing. So
and the provider asks you, how long have they been having these? And then what are you going to say? Like 6 hours? Like, and I was going to call you, but then I didn't because the beeping stopped. That sounds crazy. That sounds crazy.
Yeah. So speaking of cardiac rhythms, sinus rhythm, got it. The big lethal arrhythmias, got it.
AFib's easy.
AFib, got it. God, heart blocks. They're like the devil to me.
Those are my, that's the subject for me. I had a song in nursing school. I forgot it. They married and then they got divorced or something.
Oh, yeah, that had to do with the P waves.
You two,
Yeah.
Prolong got divorced, then they're together, but they're separated, so they're off sync or something like that.
Yeah.
It's a ridiculous song, but it works because heart blocks are very difficult.
We will put a link. I will find that.
You're fine.
And
Yeah.
I will put a link to that in our show notes
Yeah.
so y'all can see it.
It was a great little song. I remembered it for a good 4 years.
Yeah,
and
we'll
after
definitely
that-
have to look that up. Because I remember, I remember Longer Drop must be a Winky Bach.
Yes.
Yeah,
Like, I remember that.
one.
But then I'm like, I know that's second degree. Is that type 1 or type 2? Like, I don't know.
And then the third degree
Ah.
is obvious to me, or not obvious, but okay, that's the one where the ventricles and the atria are not talking at all.
Not talking at all.
There's no
Yes.
convo going on.
No.
Right.
And that's the OMG, y'all, we got to do something now.
Yeah. Yeah.
It just got real.
Super real.
Situation.
Really quick.
Yeah.
But then the Mobits one
Yeah.
is the one that throws me off.
Yeah, that one is too. Yeah.
Yeah. All right. Yeah, we got to find that song. I was just.
Well, and then I
I'm like,
also-
I want a magic cure to help me remember that.
Well, and I know a lot of people, and I remember.
I've been
the
a nurse
picture
for
of the
17 years, and I
guy
still
that
can't
does the
remember that.
dance.
Oh, the little stick man?
No,
The doctor.
that's right.
There's a doctor?
So he's in
There
white
was a
coat.
video. Yes.
I'm gonna put a link to it on these show notes. But he does he does this little dance.
Really?
For those of you that
Yes.
are
I have
listening,
to
I
watch
am
that.
doing a little.
She's
dance.
doing a dance,
Really?
and I was really contemplating getting up and doing it with you. So
But it helps a lot of people, yeah, because he does like his arms with the P waves.
That's
going.
Oh, yeah.
And it's very helpful.
Oh,
Yeah.
visual. Oh, I need
Yeah.
that.
But I think it's important for us to let people know that blocks are challenging.
Very.
They are.
You're
Very
not a
challenging.
stupid person if
No.
you're like,
No.
oh my gosh, I had no idea my patient flipped into a second degree block.
yeah. Well, the thing is you need to know what normal is. You might not be able. I might not be able to identify that this is second degree type 1 or type 2.
Correct.
But I can call the doctor and say, I don't know what in the world's going on here. There's something. Can I get an EKG?
Right, that's
Whatever.
it. That's it, yeah.
Like, because and having those resources there. So you don't want to just say, something's not right. It's something. Having a book that's got your EKG blocks in it, having a good, reliable resource provider, not getting an EKG. I mean, I remember I had a patient in MRI, this is a neuro patient, and they do have cardiac issues, y'all.
Yeah, oh yeah.
God, all
You're
kinds
stuck
of
between
them.
a rock and a hard
I
place, and you
bet.
got neuro
And I,
issues.
Oh,
right.
Lord, yeah. They
Yeah.
have 2 different goals.
Yes, they do. They do. And we can debate those. But
Yeah.
anyway, but I had this patient in MRI scanner, and I'm in critical care, so we have to have the monitor on, and I'm watching them. And, you get a lot of artifact when a patient's in MRI on the
Yes. Oh,
on the
yeah, all
monitor,
the time.
tons of
Mhm,
artifact. But, the scanner stopped in between a series of scans, and I looked at the EKG, and I went, yeah, bring him out right now.
Yeah.
Right now. And the tech's like, what's wrong? Like, the SAT's good, blood pressure's good. You know what? I said, just no. I don't do cardiac. Bring him out.
Yeah.
So I put him on my monitor, and I'm staring at it going, I don't know what that is, but that is not normal. And I brought him up to the unit, and I'm glad I
stopped the
did.
scan.
I did. I stopped the scan. I didn't.
Were they upset?
Look,
They're always mad. They're like, well, we're almost done.
well, the MRI techs were
They get very
very,
Because they
very
probably
upset by
get
that.
the brunt of
Yes.
why didn't get the scan get
Right,
done.
Right,
yeah.
right,
Very
right.
true. Very
But
true.
you know what? I have no interest in coding a patient in the MRI
Could
scanner.
you imagine? Oh,
I
Be
almost
awful.
that's
did
my
once.
pain.
Yes.
Oh my
Almost did
gosh.
once.
But I'm glad. By the time I got him, it takes 5 minutes maybe to get from MRI to our unit.
Oh, good.
By the time we got back up there, he was symptomatic from the block that he was in.
Wow.
So I'm thinking to myself,
Had you let that go?
Yeah.
I am
could you
so
imagine?
glad I was paying attention because, and I didn't know what block it was.
Right.
I just knew that something wasn't right, and I was not having issues while I was in MRI
And that's
scan.
all you have to know. You don't have to know how to read a 12 loop. You see a rhythm, it changes drastically. You have, a team. It's a collaborative effort. It's not
Yes.
all on your shoulders.
Yes.
Yep.
You just know that this is abnormal for your patient. You present that, get a 12 loop, that's it.
Yeah,
Yep.
and I've noticed a lot of admission order sets have that kind of default order that says, for rhythm changes, obtain stat EKG.
I've seen that
so
before.
that you can get that.
And if
before
it's
you even
built in, you
call.
can.
Yeah.
Yeah, if that's part of the order set, and it's helpful to know your admission order sets and what the orders come with. And I think that was part of our ICU one where if we had a rhythm change, we could go ahead and get an EKG and then call the doctor, which was great because it saves time and it cuts down on things. And I'm not sitting here trying to interpret what's going on.
And even if there is an issue, cardiologists aren't asking you what the P wave is.
Right.
They're like, let me see the 12 lead. Like, I don't need you to interpret. I'm a cardiologist. Just give me the tools so that I can diagnose. I don't need, but I do need you to alert me of a problem.
Yes. Yeah. And that's your job as that cardiac ICU nurse or floating.
Because some people are like, well, I don't know when. If it's abnormal to you, I would rather get a 12 lead and a cardiologist tell me, that's fine, that's good.
Yep.
Then I feel something's wrong. Something eventually happens. I could not live with that. I would lose my mind.
Yeah.
Knowing that I didn't go with my gut and do something and be proactive, and then I waited to allow something to happen before I acted. That would kill me.
So do you think it's fair? Like I think about one of the questions I have is when does a nurse freak out? And is it fair that if they're symptomatic with whatever rhythm they're in, it's fair to freak out? And by symptomatic, I think if they're feeling bad in any way, short of breath, they're having chest pain, if they're diaphoretic, if they're feeling dizzy. I mean, you think that's a fair statement to make?
Oh, yes. I've had many patients tell me they just don't feel good. And then I'm hovering and I'm charting in the room and I'm not leaving the room.
Yeah.
And then I don't know what's happening with you. Your vital signs look fine, but clearly there's something happening that I can't see. I'll do a focus assessment, cardiac. I'll do it again 15 minutes later. And people are telling me, quit being weird. Your patient, they're anxious or they don't like hospitals. And every time that has not been the case. Every time it's something that delayed and happened like 30 minutes later. Or they just code. Sometimes there's no warning. Code happens kind of at a hill process. They're not going to feel good. They're not going to feel good for a long time. Then they're going to get really sick and then they're going to get really sick. Then they're going to code. Not anymore.
Yeah.
They don't feel good and then they just close their eyes and they code. Sometimes it's just that
They
quick.
just drop. You get a patient out of bed for the first time and they throw a
the
massive PE.
Oh, the out of bed.
You know? Like, that's
People are
just
like, why
it.
are you so nervous? I said, this person's telling me that they feel weird and something is going to happen to them. That is not a term that people just use.
Yeah.
Well, what is that, impending doom?
Yes.
Yeah.
That is real. Like,
Yeah.
I feel like I'm going to die or I just...
Yeah.
Oh my gosh,
Yeah.
something
Yeah.
is going on. That's a real phenomenon that if your patient is verbalizing that's you, even if you don't have something quantifiable, it's like,
Pay attention to that.
normal.
Right. And
Pay
people always
attention.
go right to, oh, she's
just
anxious.
anxious, yeah.
She's nervous, and that's fine.
It's just a history of panic
until I'm proven
attacks.
wrong, it's something to me.
Yeah.
Until I prove my guess wrong, I'm going to treat it like it's something.
Yeah. And to Nicole's point, sometimes codes just happen out of the blue. My last code was a patient who, and I'm so glad that we don't have that many codes in my unit, but the alarm went off on the monitor that the blood pressure didn't take. How many times does that happen? Somebody takes the blood pressure cuff off, they forget to put it back
therapy.
on, or
Yeah.
whatever, and
So
I'm like,
true.
dang, I have so much to do, but let me go fix this alarm. And thank heavens I did, because the reason it didn't take is because the patient was in PEA.
Yeah. It's
And
so
I was
okay
like,
to read it.
yeah.
That happens to me all the time.
Yep.
I tell people, just because something's not beeping loud, it
Right.
doesn't mean that you get to ignore it.
Yeah.
Or like, oh, it'll recycle in 15 minutes.
Yeah. No.
Can you imagine waiting?
Yeah. So, I mean, it was like, and here I'm looking at the monitors, I'm walking in the room knowing that I've got to silence the alarm and fix the cuff.
Right.
But the monitor says she's in sinus rhythm at a rate of 70,
Right.
which is
Nothing's
not your
wrong.
typical PEA,
Right.
scenario anyway.
Yeah.
And then I look at her and I'm like, oh, okay, something's wrong. And then I'm like, oh, something's really
Real
wrong.
Yeah.
I jumped up and
Grab that code card.
Yeah.
So, but anyway.
So we have codes often.
Yeah.
Yeah,
We
so
have
that's a
codes
different...
very, very often.
Mm-hmm.
So our charge nurses are way more diligent about what is beeping. Somebody go in there.
Yeah.
And at first when people start working on my floor, they're like, why is everybody so tense? Why is everybody so neurotic about alarm? It's because we have a code usually every 6 hours, two a shift usually.
Really?
So it's like we have been through this where you don't think it's anything and then it's something and you got to make that call, and that call terrifies me to no end. I think just the fear of the call is what keeps me diligent as a nurse. I hate that call.
Yeah.
Something happened. You weren't here.
Yes.
This is where we are. I hate that call. It doesn't matter if they're 19 or 91. It's still very tearful, and you hang on to it for a couple of days.
Oh,
And
yeah.
I don't want that call, so I try to be as proactive as I can.
Yeah. That's such a good point too, because when with our neuro, we don't the codes don't happen anywhere near as often, I don't think. And you get, as working in the cardiac ICU, that is the name of the game.
And even the medical ICU too.
You get very used to that. So the sooner that you can get used to, because my first code, I froze
everyone does.
Everybody,
everyone does.
Getting used to that environment and how your team does it, because some people do the whole kind of race car thing where one person does this and they always have this job, or so knowing what your role would be when that happens, because it will, is really, really important. And also familiarizing yourself with the code documentation is really important. That's like a piece that it's like you get so focused on the patient stuff, but a lot of times, or not a lot of times, but a lot of times you go in there and then everybody's doing the thing. Someone needs to record.
Who's recording? And they're like, it's like, cool. You guys have been coding for 20 minutes and nobody has any pen and paper out? Okay, this is problematic.
And I'll admit, I hate it. I've been a nurse for 17 years.
What's your name?
I would do some chest compressions with the best of them.
Me too.
Let me give some meds. Heck, I'd even bag. Not a problem. But I hate documenting.
I'm not going to lie. I liked it.
Do you really?
I did like the code
documentation. I liked it when we first went to EMR, because I was a super user for, the EMR. So,
cool.
I got to help train. Anyway. They had the super users going to every single code for that reason, because everybody was new on EMR. So that was one of the things that it did in our training, is that we went through this, it's really not that bad. And honestly, if you use it,
you have to get used to it.
You have to, it's really not that bad. Right. And then the more familiar you get with codes, you anticipate what's going to happen. They got epi. Well, in 3 more minutes, they're going to get more epi, or.
Not that you just feel comfortable with someone almost dying or passing away, but you have the confidence to know what to do. I've been in this setting before. I know what roles need to be done. I can now take more of a leadership role, maybe, sort of, instead of just hanging back and crying and shaking. Because it's scary. It's still scary to me.
And it should be.
Yeah, it should be.
It should be.
Yeah.
People that are like, oh, you'll get used to codes, when you've been a nurse for 20 years. I don't want to get used to somebody dying. That's not a good thing.
Well, and let's be real. They're coding. They're dead.
Right, yeah.
That's true.
I mean, they have died.
Yes.
Hopefully we get them back.
Hopefully, yeah.
But they have died.
Yeah.
So, I mean, you literally just witnessed somebody die right then.
Yeah.
Where you guys work at, do you guys do where the family can come in?
Yeah.
Yeah. We've done that too.
Yeah.
I mean, most of the time, the majority of the time, especially if the code is happening on a floor, the rooms are smaller. So then we do have to sometimes ask excessive people to step out. Right. But there are many times that we now say, no, stay. Watch what we're doing. It's okay for you to see this. Let me, see us working really hard and
watch it. It
changes decision making.
They're like, wait, this is what this is? I thought this was going to be lighter and it wasn't going to be as chaotic.
Yeah.
And blood wasn't going to be everywhere. It's like they see and they're like, oh, okay,
yeah.
I don't want this.
It's not like TV.
Yeah.
It's not like TV.
Not at all.
So to take advantage of your multi-organ experience, so sometimes it's challenging to differentiate a cardiac issue from a lung issue, right? So somebody's having chest pain or they're feeling short of breath. Is the EKG the only way to differentiate, you think, between a lung and a heart problem, or do you think there's other things that can help you try and quickly make that call?
We do ABGs on everybody on our floor, so usually it's 12 lead ABG.
Okay.
And that's kind of our two.
They go side by side.
Yes, yeah. The ABG tells us what's going on, what's going on pulmonary wise, and then the 12 leads the cardiac, and then everything else, UA and lab and things like that. But everybody on our floor gets an ABG, and it's very painful when someone's awake. It's one thing when you're knocked out and you got propofol, and they're like, "Oh, let's do a quick ABG." It's one thing when you have a 9-year-old and she's awake, but she feels really tired and she's not breathing or satting very well, and we're like, we're gonna stick this needle in here, and you think that's
your artery,
it hurts,
and we're gonna hold pressure for a while,
for a very long time, and she's on warfarin. It turns into a whole thing. But I need that result to find out if you need BiPAP or I have to intubate you. I need this result.
Yeah.
But just convincing them of the measure is difficult within itself. But yeah, I would say ABG and then 12 lead.
ABG and 12
so knowing your diagnostics is important, and not just going off of the O2 stat.
Yeah. And I mean, and truly realize that it can be lung or cardiac, and sometimes it can be both. So
people have a lot of comorbidities, a lot of issues. Sometimes it's not just white and black. They have hypertension. They had a stroke. Now they have COPD. It's like 12 disease processes in this one person. It could be a mixture of everything.
And they're like overlapping.
Yeah, they're overlapping.
All right, so to round out our episode, I want you to step up on your cardiac soapbox for just a minute. Okay? And you've got all these brand new cardiac ICU nurses standing in front of you. What is one thing that you want them going on to their first day in the unit that you want them to know?
I would tell them to be your patient's detective and advocate. There are going to be some things that people tell you that you have to investigate yourself. Nursing and even healthcare, this isn't like a friendship thing or a personal thing. This is me taking care of someone who's sick. I need to confirm orders. I need to make sure what you're telling me is true. No one should be getting mad at you checking orders. Some people get very upset. I'm just making sure what you're telling me is true. This is my license. This is my scope of practice. I'm sorry you don't feel that way, but you need to stand up for yourself. And the detective is, you need to make sure that if you feel something's wrong, call somebody. I work on nights. I wake people up all the time and they get upset. And when I'm right, it feels great. And when I'm wrong, it's like, okay, you know, that wasn't good, but I now know that that patient's okay. You can yell at me all you want. I now feel good and I know that this patient's okay. Do not be afraid to communicate or call or collaborate with your charge nurse. This is a team effort. No nurse has all the answers. I might not know what a complete heart block looks like, but it's not sinus rhythm. This is sinus arrhythmia. I don't know what's going on. Let me talk to my charge or get the consult or call the attending physician. Do something. Act on how you feel. Obviously within your scope and obviously with orders, but do not be afraid to trust what you know. You don't have to know a 12 lead, but you know if something's wrong. GNs don't have a lot of experience. They're very, very new, but I've seen a lot of them be scared to say something, and they're like, oh yeah, I thought that was going to happen.
Yeah, and they were right. They were scared to say something, but they were right.
But they were right, and it's like, it's sad, and it's like, why didn't you? And they're like, oh, I was scared, and I didn't want to call the doctor, and it's like, honey, if they're on call at night, calls are expected. I said, you have to get a thicker skin. People, they're going to be upset. People are upset with me all the time. I just plead my case, and what do you want me to do? If you don't want to do anything, that's an order to me. My orders are not to do anything. We'll continue to monitor. That's completely fine. I've done my due diligence. But most of the time, when you feel like something's wrong, something is definitely wrong. People are living a lot longer with a lot of disease processes that cause a lot of issues. We've had patients get cabbaged at 95 years old.
Oh, I had a 93-year-old cabbage once.
Yeah. The rules are changing. There is no more like, oh, she's 70. We're not going to do this hip fracture. Yet they do surgery. They might not get off that vent anytime soon. You know, Peg Nursing Home, but they do surgeries on people who are older. And you're dealing with a lot of comorbidities and issues. So if you feel like something's wrong, I don't like the vent modes. I have no idea what's happening with that. Respiratory, hey, can you come over and look at this? The peak pressures are really high. I don't know what's going on. I've suctioned them. Can you please help me? Yeah. Some nurses are like, oh, well, you know, if there was a problem, they'd come over here. No, that's your job as the nurse to notify. ICU has a very tiny gap of what you can wait on until it turns into something. It's one thing if they're a walkie-talkie 19-year-old. If they're coughing, they're not going to go on ARDS. They're 19 years old. They have no issues. When they're 95 and they have COPD, you have a tiny gap before that turns into a bigger issue that they might not come back from. So I'm just naturally a nosy person. What's going on? How do they feel? They're telling me they feel weird. I'm just going to call anyway.
So be a detective. And then be an advocate. Advocate
for your patient. People are always like, why are you calling a doctor about pain medicine? Her systolic is 200. Clearly something's wrong. People tend to think that people who are in pain, if they're not doubled over and crying, it's not real pain. As I had a C-section, I was sitting there like completely fine like this. My pain was 10 out of 10. I was in agony. It hurt. Pain is displayed in different ways. But symptomatically, that systolic is 200. I can match that. Even if it wasn't, I would still call. I hate to see people in pain. Regardless of what's going on, 19, 90 years old, I still call. And if I get no orders, at least I can go back to that patient and say, you know what, I tried to advocate for you. The doctor said no, but can we do something else? But I at least try. I work in nights. I'm used to calling, but everyone's like, you call doctors a lot. I don't know how to diagnose. I know my scope. I know my role, and I don't ever step out of that. So I'm one to, can you call? Can you make sure this is okay? I'm not really sure. Chest tube output 500 in an hour. I mean, can you come look at the patient, the surgical fellow, and they come by. If you speak on the issues that you're having, most of the time, somebody will help you.
Yeah.
It's when you're quiet and nothing happens, and then they code, and people are looking at you like, why didn't you catch that? Like,
Yeah.
what were you doing?
Why didn't you tell me?
And then it turns into, this is your fault thing now.
Mm-hmm.
And that, I can't live with that.
Yeah.
I cannot, it drives me crazy.
So diligence is key.
It's key, especially in the ICU. Well, in nursing in general, but especially in ICU, because they're so sick.
Mm-hmm.
They're so sick, and people pass away, teenagers, adults. There is no demographic for passing away.
Yeah.
It happens so quickly.
So to kind of summarize the episode, so if you are a new graduate nurse, you really highly advocate for you to know the anatomy of the heart inside and out, structurally and mechanically, or electrically.
Yes.
And focus on knowing that stuff first, and then get to treatment. So once you know that stuff inside and out, really kind of move on to knowing the treatment. So don't kind of flip that. When you're floating to the cardiac unit, make sure that you're paying attention to those alarms, the trends that the patient is having, and not waiting too long. Making sure you're investigating all your alarms. If you're not sure if it's a lung or cardiac issue, noting the ABG versus the EKG, and then noting that it might be both. Noting that potassium, which is something that cardiologists really, really care about. Your electrolytes, huge, big with your cardiac patients, and making sure that you're being a advocate and a detective for your patients. So thank you guys so much for joining us. Thank you, Nacole, for being here.
Thank you for having me.
We will post show notes where we have links to Nacole's blog and her resources, as well as those videos we were talking about.
I can't wait. I'm excited.
And additional cardiac resources to help you guys be successful in the cardiac ICU progressive, floor kind of setting. So thanks, nurses, and stay fresh.
Damn girl, better hit the floor. All the other fellas better run for the door. Stop, drop, and roll with me. I got